Well, good afternoon and a very warm welcome to today's webinar, which is on the transformation of community mental health care. My name is Brian Dow, and as you can see there from that screen, I'm the Deputy Chief Executive at Rethink Mental Illness. And it's my huge privilege to be chairing today and welcoming not only so many of you who've joined the call, and my apologies that we've started a little bit late. We're just waiting on Claire Murdoch coming along. No doubt she has been caught up in something else. But also
I'm in, but I'm joining by phone link.
Claire,
I can't get in through the link. Sorry to interrupt you, Brian.
Not at all. Really glad to have you there, Claire, and thank you very much for that. I think it will more or less feel the same, hopefully, to our attendees. Although they'll be deprived your physog, but I'm sure we'll manage, because your words will more than compensate for that. So thank you, Claire. Nice to hear from you. So just to run through the hygiene stuff first, if I can. So we have, well, about 55 minutes or so, I guess. We're going to hear from our speakers for about 25 minutes or so. We're going to start off with Claire, and then on to Kate, and then on to Mark, who I'll say a little bit more about in a second. If you do have any questions, do please send those throughout on our Q&A function, and they will be forwarded through to me by the magic of WhatsApp, and hopefully I'll get a chance to then convey those to our guests. So do those at any point that questions occur to you. I'm sure that you're all sitting there with thoughts on your mind at the moment, but that would be really welcome, and obviously helps the second half of the webinar. And just to say that if we don't get to all the questions, we are going to find a way to make sure we ask those of our guests, and we'll make a point of following up with those afterwards, but I'll come on to that in due course. So back to the event itself. I mean, I think it's impossible really to overstate the importance of this moment in the community mental health sector. Rethink Mental Illness has campaigned for many decades to establish a level of parity between mental health and physical health, and there have been many barriers along the way to making that happen. Firstly, we've had public attitudes and the stigma that creates for people. I think it's reasonable to say that governments of all hues in the past have not really prioritised mental health in the way that perhaps they have prioritised physical health. And I think we have to say that in times gone by, there has been a leadership question. Has there been the drive on this issue? But I think now is the time that we can right that historic wrong. And we have two things, I think, very much in our favour. The first is that we have that commitment at the top of the NHS, which you'll hear from in a second. And I think that's true also at a local level. But that's now reflecting the concerns and the desires of the public at large. I mean, I think survey after survey in the lead up to the, 246 general elections it feels like we've had over the last few years, mental health has come out as a much higher priority for the public. So it's really creeped up the agenda, and of course it will be even more so at a moment like this. And I think that commitment we now have at the top of the NHS has translated into, and Claire won't mind me saying this, I don't think, a doggedness to really fight for our corner. And at a time when we had an extended period of austerity, I know that the commitment that has led to record funds which are about to go in through the system have not been possible and have not been achieved by other government departments. So I think that commitment, that doggedness to see that through, leaves us in an incredibly good position to have a transformation hopefully about to take effect, but that won't happen on its own. I think equally on the other side of the on the balance sheet, it would be remiss not to mention one of the things which make it far more challenging, namely the pandemic that we are all living through. Just at the point, I suppose, we were kind of ready to amplify that transformation, the system has literally been thrown up in the air, and the front line, as you all know, has been redeployed to deal with that crisis that's presented itself suddenly out of nowhere. But even that said, and I'm sure Claire will speak to this, I think what the pandemic has demonstrated is the art of the possible, and things have happened during the pandemic that we probably did not believe could have happened. So I don't think we should see the pandemic as a barrier to making everything happen. It's an additional obstacle for certain, but it doesn't mean that we can't make that transformation agenda realised. So I think without further ado, let's go through our speakers, and obviously we've been joined by Claire on the phone. Claire, I think, needs no introduction, but nonetheless I will say is of course the National Director for Mental Health, and I think it's true to say that we could not have a better friend on this issue at a more important time, and Claire will speak about the transformation that she's trying to make happen with all of you. Secondly, we're going to hear from Kate Hall, who will talk about her experience of caring for her father, who had a severe mental illness in the community. And then finally, we'll hear from Mark Yates, who's the Director of Operations at Rethink Mental Illness, and talk about our experience in working with one of the pilot areas in Somerset, who I know we have a number of colleagues on the call, and that's been a really incredibly positive experience for us and informs how we can begin to help other STP areas over the coming months. So I'll hand over to Claire. Claire, really fabulous to have you here, and let's hand over to you.
Brian, thank you so much for that. And before I just go into the presentation, may I just ask, are the slides that I'm going to speak to on the screen for people? Don't worry if they're not, but I can't see what you all can see or not see.
We can currently see a picture of you with a logo of Rethink, which is a nice prospect, but now we've got the slides up on our screen, so yeah, we can see those.
Oh, lovely, thank you. So we haven't got many slides. Thank you so much. Thank you. I just wanted to get that bit of housekeeping out of the way. I'm so sorry that my link isn't supported on my iPad Pro, so when I tried to join you, I couldn't through that route, but as you say, Brian, you've been spared my face, which I think there are many would think is a blessing. But can I just say a huge thank you to Rethink and all of your members and activists, campaigners, and people who are living with serious mental illness or mental health problems, who have, thousands, if not millions of people across the country have really insistently and often at such high personal cost determinedly tried to make policymakers, funders, frontline practitioners, people like me, aware of things that need to change. And I just want to congratulate Rethink, because I think you're a superb organisation and you bring together some of the brightest and best people I know from all kinds of backgrounds to make the change possible. So thank you hugely, and thanks for asking me here today. Just by way of introduction, some people will know me, I've worked in mental health services for 37 years now, and I can't believe it is 37 years, and recently visited my best friend's daughter, who has bought her first flat up in Free Barnet, which used to be the hospital I trained in. How times have changed. So it's been a long time, and at times it's felt like pushing water up a hill, trying to get mental health the priority it needs and deserves. But right now it still feels really tough, and even that, but so much better. I think, Brian, you're right when you say this is a moment in history we cannot waste, and we're getting priority even when the country now is 2 trillion in debt. At the moment, the commitment to the long-term plan, the 2.3 billion additional investment in frontline mental health services by 2023 that we have secured, as well as people will have noted at the weekend, and not before time, might I add, but nonetheless at the weekend, government announced over 400 million to end dormitory provision in this country. Now, so I should think, but we are a country that's 2 trillion in debt and in the grip of a global pandemic, and I think it speaks to the importance of this issue, mental health, and the fact the country needs to do better. That capital announcement has survived, if you like, when clearly Treasury is having to take a long, hard look at all it spends its money on, our money on currently. So I'm excited about the advances we make, but I don't for one moment want that excitement or feeling of positivity to overshadow the fact that too many people are still spending too much of their time not accessing not only the services that they should access, but also the other supports and the other avenues and routes into being contributing members of society. I think we've come a long way, but we've much further still to go. I think we had the 5-year forward view for mental health, but over the last 2 years, we've superseded that by the long-term plan. Now, what's really exciting in the long-term plan, obviously, is that of the 2.3 billion I mentioned earlier, nearly $1 billion of it, you can see the little piggy bank on the slide and the 975 million, nearly half of it will be invested in community mental health services to pay for, in particular, the expansion, and not just the expansion, the improvement and transformation of community services for, in the main, people aged over 18 years and older. And we think that that will enable us to see 370,000 people a year more by 23-24. But we really don't just want more or more of the same, though many thanks to colleagues who've done a great job in recent years. We want different and better. And if we can go to the next slide, please. And many thanks to my national team colleagues who are working with yourselves and other organisations, thinking about how do we get the best bang for our buck in terms of that nearly £1 billion, and what really should we be aiming to deliver by way of transformation. And that is why, by the way, the work that you've been doing in Somerset and other places as Rethink, looking at how do we bring more people into the model of care. So it's not just the NHS on diagnosis and treatment, which is a small part of somebody's life. It's all of the other organisations and community assets and strengths that sit around our ability to really support people to live their best life possible. So we know we want a core model that you can see on this next slide, and then a dedicated focus, and a big focus in particular on physical health, support back into employment, IPS, and we want to keep a big focus on early intervention in psychosis as well. So there are some, if you like, givens that we built into the ask to try and get this money into the service. And these are the components that just are not negotiable that you can see on the slides in front of you. I suppose a big one in terms of the model of care is that whatever we put into it, it must be based in local care networks, primary care networks. It must be working with third sector organisations, schools if we're talking about children, community groups and so on and so forth. It has to be successful, we believe that community mental health services need to be deeply anchored in the local. If we can go to the next slide, please, because I want to leave time for other speakers and, of course, questions. But we've identified 12 early implementer sites. So the long-term plan runs for 5 years, and we're in year 2 currently. If you like, the big CMHT money, you can see the pound sign on the next slide, which says that we particularly now over the next 3 years, from next April onwards, the financial years run from April to April in the NHS, there'll be 782 million of that funding will flow in, and 120 million of that funding will flow in as of the coming April. And it will be shepherded by the ICS, the Integrated Care Systems, or STPs, just used interchangeably, but it's where clusters and groups of CCGs and providers come together across a bigger footprint than just one borough. So this money will be shepherded into the front line by ICSs and ICPs. We've already identified 12 early implementer sites in years 1 and 2 who are testing all sorts of things for us. So we had 70 million to support the 12 early implementer sites. And the sorts of things that they've been testing for us are, what about a better focus on adult eating disorders? What about better talking therapies and other things for people living with psychoses? What about the transition that currently can feel so awful between 18 and 25-year-olds, and how do we do that better as youngsters with mental health problems become young adults and adults, and how do we do that better? But also, and importantly, can we test access and waiting time standards? Wouldn't it be lovely if people could be seen in CMHTs between 1 and 4 weeks, depending on urgency, and if we could really do away with waiting times that are so bad for people's mental health, and we could make the services more responsive, so you've got the clock up there. So we're trying to pilot various things so that when the bigger money, the 782 million, comes in for the next 3 years, we've got some really clear steers that we're giving to the system. If we can go on to the next slide, and as we do, it's just to note that we want to keep driving these developments, even though we've got a system under extreme pressure with COVID. It's not something we can ignore. It is a fact of our lives, and certainly in wave 1, we saw some slowdown of our developmental work as we really focused on keeping our existing client caseloads, patient caseloads, seen and engaged and supported. Well, we can't afford to see that interruption in wave 2, and we know colleagues in the north and communities and citizens in the north of the country maybe feel like they never even really left wave 1 and they're already in wave 2, and we've heard the news about Liverpool, so our hearts go out to everybody there. What we're trying to do is make sure that we keep a real drive around this expansion and investment and transformation. So I've already said a bit about the service model. We want as well and the pilots are looking into this as well, this dreaded term personality disorder is another group of patients or service users that we really feel get a poor deal from services as well at the minute. We don't feel there's been enough focus on people living with serious mental illnesses and psychosis, and this is our opportunity to correct that. We definitely want more trauma-informed care, and we definitely want to stop mental health rehabilitation units kind of being outside of local areas for residential care, far from home and disconnected from local communities, and we want our community model to anchor people back locally. And I guess the other thing I want to say on this slide, I'm not going to take you through all the points, but is if we're going to see more people but better, more appropriately, more flexibly, more innovatively, if we are to move mental health services to place greater value on the totality of people's lives, not just the assessment and treatment piece, and that is what we're determined to do, we have to work with other partners, and our voluntary sector partners, it seems to me, are absolutely front and centre of how we ought to be both planning but also delivering changes and improvements in care. I also think we need to, on staffing, if you could go to the next slide, and as you move it, I'll just say something about staffing on the last slide. My next slide is also my last slide. On staffing, we want to bring many more people with lived experience into explicitly working in mental health services, more peer support workers, and more people with lived experience into all kinds of roles. And I do believe that we will have a more compassionate, more flexible service, the more we can stay in touch with what's it really like living with a major mental illness, what things really matter, how do we really invest in what matters most to people, not what matters most to professionals. And just finally, I suppose that we are absolutely, and I've said most of this already, so I'm not going to talk to it for long, we're absolutely determined to do not more, but more and different. To do that, we need to listen to carers, to service users. We need to work closely into primary care. One of my great wishes is that we stop this referral between primary and secondary care of people who have got a mental health condition that they may be living with for life or for years. It seems to me it makes no sense to go, oh, you're for primary care or you're for secondary care. We've got to stop this, and instead of moving the person between primary and secondary, which makes little or no sense to them, we need to move the resource in around them as their needs change, and that resource absolutely needs to include working with voluntary sector partners and people with lived experience. I've said enough. I just want to say thank you for listening to me. Thank you all of you who've campaigned to get us to the point where we've got this additional investment. And I mean what I say about the different and better, not just more. So your help and input and questions will be much valued.
Claire, thank you so much. And we know that you mean what you say, and we profoundly welcome that point about the system revolving around the person rather than the person trying to find his or her way through the system. I think that in a nutshell encapsulates what we really should be trying to do in terms of a longer term vision. I'm also struck by that point, the point you made earlier on about the best life possible. And our next speaker, Kate Hall, I think it gives a really good example of how, while it's easy to come to a conclusion about what isn't possible if you have a severe and enduring mental illness, with the right kind of care and support and the right kind of model that Claire described so eloquently, actually you can live a far more meaningful life. So, Kate, let's hand over to you.
Lovely. Thank you very much, Brian. So I am the daughter of a man called Clive Butterworth, and I'm just going to show you his photo because he's not here, but I always think that it helps to be able to see a face. This was him on his wedding day back in 2013. And this is just another quick one because I love it. It's him and my little boy when he was a baby. And I just think they look so uncannily similar that I just love that photo. So that's him. He was a wonderful man, and he lived with schizoaffective disorder, which he was diagnosed with in his early 20s. He, despite that, was a really shining example of what is possible for people who are living with serious mental illness. And we are just desperate to share his story really as widely as possible, because we hope that it can create a legacy of hope and show that there is a way that people can be contributing and really valuable members of society. So Dad struggled with quite a lot of shame to do with his diagnosis, but he was just fiercely determined to not let it hold him back and to not be defined by it. So he had 3 careers over the course of his lifetime. He started off in marketing, working at Unilever and Vandenberg's. His claim to fame, which he was so proud of, was launching Strawberry Hubba Bubba, which some of you will probably know. And he also wrote the line "spread straight from the fridge" on Clover packaging, which I think has been taken off now, which he was very upset about. But anyway, when kind of stress sort of became too much in that role, he retrained and he went into teaching, which I'm not sure I would consider to be a less stressful existence, but he went to teach secondary school boys business studies and economics. Then he went into higher education briefly before finishing his career as a civil servant, working for the Inland Revenue in an administrative role. So he kept going, and he kept kind of changing as he needed to, dependent on what his capabilities were, and managing obviously alongside the illness. He was brilliant at maintaining really long and lasting friendships. His oldest friends he's still in touch with from primary school. And they were a source of great support to him over the years. Dad was a single parent to us for some of his life. My parents divorced when I was 9, but they maintained a really strong and solid friendship, which again was a huge support to Dad during difficult times and times when he had breakdowns and was hospitalised for periods. But despite all of that, he was just such a devoted father, and he would be there every other weekend without fail, you know, unless he was in hospital. And he would take us on trips. He would take us, you know, visiting friends and relatives all over the country. He would make our time together as special as possible. And he was just he took his duties and his parental responsibilities really seriously, despite, you know, obviously having a background of a serious mental illness that he was also always managing. But he was really careful to try and shield us from that, particularly, you know, when we were so young that we didn't really, you know, understand the realities of it. He got remarried in 2013, as I said, after his last really serious breakdown where he was sectioned for several months back in 2001. Some friends of his that actually his best friend from primary school was worried about him, and they recommended that he joined his local church in Aylesbury, which he did. And it was hugely important for him actually at that point, because he was at a very low ebb, and I was going off to university. I was worried about how he was going to be, and the church just took him in, and they gave him it gave him a renewed sense of purpose. And when he retired, when he was just before he turned 60, he threw himself into church life, and he was given roles and responsibilities that helped his self-esteem, particularly that had been really damaged after what happened in that 2001 episode. So it was a process of rebuilding, and the church was so fundamental in that, and we will always be forever grateful to them. He through the church, he kind of led a very full life, and he stayed very active. He used to, in his younger years, play football and cricket and rugby, and that then became walking football when his knees gave up. But he used to take the older, more elderly members of the church out on day trips. He'd take them to appointments for, doctor's appointments if they needed to. So it really gave him purpose and a sense of value. And actually, he obviously isn't here. He died, unfortunately, in January, and that was because of a transition from olanzapine onto a new drug that was aiming to prolong his life and protect his physical health, because olanzapine had led to chronic pancreatitis, which he was really suffering with, and he had such a high pain threshold. But nevertheless, we knew that he was in a lot of pain, and it was something that wasn't getting any better. So he took the decision to transition, and it was going very well, seemingly for the first few weeks, until very suddenly overnight it then was not going well, and unfortunately he died. So that's obviously been something that we've been coping with over the last few months against the backdrop of COVID. And in the days after he died on the Wednesday. On Sunday, we went to church with Pam, with our stepmom, to support her. And obviously they were going to talk about Dad at church because he was such a well-known member of the community. And I just took a moment to gaze around, and I just looked at really how many people were so obviously in need. And that was just really kind of on the outside, and there's probably so many more people who were in need on the inside who I couldn't see. But it just struck me that the church was holding those people and providing such a vital role for them. And religion aside, I'm not a regular churchgoer, but I could just see that there was a need that they were fulfilling. And I just had the question in my head of where would these people all be if they were not in church today? So despite Dad's death, we are really determined that his legacy, like I said, should be one of hope. It should be one of hope that for people living with severe mental illness and their families, that they can be really highly valuable and contributing members of society. And it should be expected that they can have the opportunity and get access to the care that they need to create the life that they want. Obviously managing their illness alongside it. They should never be made to feel sidelined. They should certainly never be made to feel like they're facing discrimination, and they should live in the hope that yeah, like I've said, they can build the care that they need. So we are really excited by everything that we've heard from Rethink, and also that was reinforced by Claire, the fact that this new mental health framework is putting the patient front and centre, and it's really important that the patient and if not the patient, then the family around the patient, who are often the next best people to speak to in terms of lived experience, they are put front and centre, and the care is built around them and what their specific needs are. And I think that would be a truly different, to Claire's point around different and better, that really would be something different and better for the future. So it being, the fact that it could be a joined up approach, combining individuals, patients, with families, with experts, with community support groups, with voluntary organisations, like Claire mentioned. That's a really exciting prospect, and we're, as a family, really keen to be part of making that a reality.
Thank you so much for that. I just think that was such a really powerful example of the human dimension of that model that Claire talked about. All those other factors that kept your dad well, being socially connected, having a job, a sense of purpose that comes with that, obviously a level of financial security that you acquire when you're working, staying fit. I mean, that is the model that we're looking to develop in a nutshell. So thank you so much for that. And actually, you've kind of perfectly, almost as if we planned it, perfectly set up our next speaker, Mark Yates, who's Rethink's Director of Operations. And Mark's just going to talk to us a bit about our experience in working with our colleagues in Somerset, some of whom I know are on the call today, really about how we've tried to work with them and other players in that community to advance that model and to make it reality there, as we are very keen to work with other areas to make it reality wherever you happen to have a mental health problem. So I'll hand over to Mark.
Thank you, Brian, and thanks, Kate, for sharing your story. I think a reminder, which we needed one, of why this work is so important. And as I'm sure you'll be aware, in signing up to today's session, Rethink Mental Illness has developed a guide setting out the first 5 steps needed to be ready for the transformation funding coming into the system next year. And as a charity, whose purpose is to provide people living with severe mental illness and campaign for change, provide services and campaign for change, we can see what a significant opportunity the community mental health frame represents to change the way we work. We developed this guide because we're committed to playing our part. We want to make the plans of NHS England a success. So it's my job to introduce the guide to you over the next few minutes. But before I go on to do so, I did just want to say a huge thank you at the start to those who have been involved in developing the guide with us. So to just name a few people, we want to thank Birrell at NHS England. We want to thank our experts by experience, Keith, Sue, Steve and Jill, our colleagues and partners in Somerset, Grimsby and Merseycare, alongside Janssen, for funding this work. So thank you to all of you for your contributions in bringing this guide to fruition. Before introducing the guide, I just wanted to start with what's a brief kind of personal reflection, and that's that I think within health and social care, we've always talked about the concept or importance of integration. That's the joining up of health and social care systems, and perhaps even a seamless connection between the statutory sector and the voluntary and community service and independent sector. And sitting on the provider side of the fence as I do, it's kind of something that we've always seen as a panacea, but perhaps kicked around or grumbled about from the sidelines without ever really doing anything about it or feeling that we were able to do anything about it. But it feels that the tables have turned somewhat, and the community mental health framework, I think, invites and perhaps provides the mechanism for the system to come together. So we're kind of running out of excuses to not think more differently about how we collectively work in the interest of people who use our services. And I think of it as the permission we probably never needed, but what we've got anyway, just for the avoidance of doubt. So there's perhaps not many reasons left for us not to begin to do this work. So that said, in introducing the guide, I just wanted to outline a couple of initial thoughts to bear in mind in setting out the 5 steps. And that's firstly, whilst the places and areas from which we've learned some of the things featured within the guide, their distinct geographies, the principles we set out should be universal. They'll help you to find the right solution in your area, to provide a way of doing things, recognising the outcomes will look different depending on what your system priorities are and what people in your area may need. And secondly, and colleagues have referenced this already, no doubt feels like a huge amount of work and significant change, particularly in the midst of a global pandemic. So it's really important to consider this as just the start of the work, and working through the guide over the next few months will not just result in the job being done, the job being finished. It's an iterative programme of work over months and perhaps years to help achieve the ambitions which have been set out. So moving on to the guide itself then, the 5 steps of a chronological order, but there are obvious overlaps in implementation which will hopefully be clear as I run through those. So starting from the top, the first is very much about identifying the right leaders and having the appropriate governance in place. So this is about understanding who in the STP has the right level of authority to get decisions agreed, the capacity to dedicate time needed to ensure that this is truly transformational, and alongside an understanding of mental illness. And on that last point, no one person in the STP or any organisation can really truly have the knowledge and understanding of the complexities around transforming a community mental health model of care. So there has to be representatives from the NHS, local authorities, voluntary sector, and certainly representative experts by experience. And those representatives have to include those people from different groups across society. such as Black and other minority ethnic backgrounds and older people with mental illness. Those individuals really need to be involved at the senior leadership level to make sure that the change which the organisation is striving for is really impactful. And although you may not want to be overly prescriptive at this stage, it's vital to agree ways of working as a leadership group. So develop a process for decision making, agree and outline terms of reference at the beginning. And on this, we're happy to share more of our own experience in the areas that we've been working. That brings us on neatly to co-production, which is the second stage in our guide. And this is key to what NHS England and NHS Improvement will be looking for in their planning process, and Claire referenced it in her presentation a few seconds ago. Co-production isn't quick, it's not easy, but it's vital to ensuring community care in your area is transformed and will actually work for your populations. And it has to start somewhere, so develop your plan early at the beginning. It can develop and build over time and can be carried on concurrently with other early actions. You must ensure that your co-production does go beyond those traditional boundaries again and ensure that those voices of underserved groups are clearly heard, and that they are able to contribute their thoughts and ideas. It must include older people who may face barriers in accessing mental health services and can use their experiences to help overcome these. We know from our work in facilitating co-production within STPs that getting it right now can save a huge amount of time and money later on down the line. We've heard it described as the deal breaker, so the thing that can help get difficult decisions made and signed off. If there are disagreements on where funding should go or who should deliver certain services, you can always go back to that co-produced model of care to help get a decision made. So have a look at our guide and again get in touch if you like more detail on how to work in partnership with local experts by experience. Thirdly, there's a huge range of support already being provided in your area by different organisations, and as Kate alluded to in her presentation, some of those aren't mental health specific, but they play a crucial role in providing some kind of support for people with mental illness. So it's really important to map those community assets to further develop your understanding of the range of different services and support networks people living with mental illness choose to access to support their recovery and well-being. And within our guide, we include an example tool to help with mapping community assets as an appendix. So again, there's a reference point for you within the guide. And I think that brings us on to step 4. So step 4 is really helping and looking at those voluntary and community sector organisations, which are really important in designing and delivering a new community model of care. We recommend identifying these groups early on and building an alliance. The key here is that traditionally the voluntary and community sector organisations and Rethink Mental Illness are part of that sector. We're used to competing with one another for contracts, and it's even more pertinent in the face of COVID effective funding levels. That actually, that competitive marketplace is something that we're used to doing and being part of. But to be successful in transforming community mental health care, we need to work together and build on each other's strengths. And an alliance of voluntary organisations who between them are able to agree the right ways of working and leadership alongside different approaches to procurement will help lead your work off in the right direction. Again, a common theme really is that the ambition of the alliance must look beyond kind of the boundaries of mental health charities and service providers. It's got to include wider community groups and smaller micro or grassroots organisations, and connecting to individuals from organisations representing diverse communities. And there's a really important role for the leadership of the STP in being clear on establishing kind of this sense of joint working with and between the voluntary and community sector. If the VCS are clear that there is an expectation on them to work together in partnership and not as competitors, then it creates that environment in which some of the usual boundaries can begin to be removed by people working in those systems and in those sectors. And again, the principles of co-production are important here. If co-production is a central driver of any service model or new development, then that can be supported by the alliance and driven by the alliance as they take their work forward. And finally, and perhaps talking to Claire's final point really, is that no system transformation can be possible if we don't consider the needs of the brilliant people who work across and in our services. As a co-produced model of care begins to form, there'll be some early signs of clear gaps in workforce, particularly when you look at Health Education England's new roles. And whilst it's important not to jump to assuming what a new model of care will look like, and that we don't recruit to all roles too early, some roles will need to be filled where there are clear gaps to hit the ground running in some areas as the new money comes into the system from April next year. So a workforce plan will need to be creative. It will need to avoid just moving people around the system and not create gaps in other places, but also recognise that will be a requirement for new roles. So bringing in, people with lived experience and peer support workers into the system. So in terms of the guide, that they are our first 5 steps. They're the things we recommend that STPs begin to focus on. They're governance, co-production, asset mapping, alliance building, and workforce planning. And to reiterate, we feel that that's going to be a big task. We know it's going to be a big task, and we'll take time to get right. But there is support available, and funding to support the transformation is on its way. So as a final reflection, then, I just wanted to share our motivation for doing this. The idea, as Brian outlined at the start, the idea of transformative care for people with severe mental illness is fundamental to our mission as a charity. It's why we were founded 50 years ago. It's why we exist today. It's why we published our document Communities That Care to help frame the ambitions of the community mental health framework around the needs of people using services. It's why we worked with colleagues across the system in Somerset, Grimsby and other areas to try and develop the concept, prove that change is possible and that the ambitions of the plan are deliverable over time. It's why we've developed the guide that we've shared today, sharing our experiences and learnings from colleagues with you to help you deliver on your ambitions for people in your areas. And it's why that's not kind of the end of the game for us. It's why we're going to continue to share our experiences. We're going to host further webinars to provide a bit of a deeper dive into some of this work, including in Somerset. We are going to host a further webinar where we hope to hear from partners such as SOMPAR, the local NHS Partnerships Trust, and the Second Step, one of the founding members of the Alliance, which is scheduled to take place on the 4th of November. We're also going to plan a deeper dive on alliance building and co-production so we can continue to iterate, learn and evolve, and we'll share more dates and details on those with you in due course. We're completely committed to the success of the NHS long-term plan and the ambitions of the community mental health framework, and recognise the key to making the next phase of delivery successful is through what happens on the ground locally in your areas. We've got a cross-organisational community mental health framework unit working on this, so we can help you to translate the national drivers into local delivery, and then as importantly make sure that we share your local experiences and understanding back into and through the national framework. So please consider attending our next webinars. Stay in touch. We'll be sharing more details after this event. And equally, if you want to talk to us some more about tapping into our unit, then again, please don't hesitate to get in touch with us. So thank you very much. I hope you found that introduction to the guide useful, and I'll hand back over to Brian.
Thank you, Mark. I'm conscious we've got about 170 odd people on the call, and a lot of questions have come in, so I'm going to try and get through as many as we can in the time that we have left, and that means I'll slightly entreat our guests to answer as quickly as, or at least as with maximum brevity if they possibly can. But just to say, if we don't answer your question now, as I said, we will kind of put those to our guests, and we'll make sure that we follow up with you. So don't worry if your question isn't aired now. I'll kind of put two, if I can, firstly to Claire, because I sort of feel they sort of hang together really. The first is a relatively straightforward one, Claire, but I'll do the first and the second. So the £975 million, someone asks, that you talked about being ring fence for the community mental health framework implementation. That's the question really. Is that ring fence for the community mental health framework implementation, or is it for all the long-term plan community objectives, for example, including IAPT? And the second question I made, which I think is a very pertinent one, given everything that's going on, just a welcome for the commitment at the top from yourselves and others, but how difficult, if you can hear this one, are you and colleagues finding it to convince Treasury at the moment to deliver on those commitments, not least because, of course, as we know, that if you like, the mental health burden, a phrase I'm not very keen to use, but the kind of overall level of population mental health is changing dynamically as a result of the pandemic. So just a sense that the recent announcements around capital are very welcome, but they obviously will not solve in and of themselves the problem as a whole. So those two questions together, Claire, if you wouldn't mind.
Thank you. And can I just, before I answer it, say, Kate, you brought a tear to my eye. I love my dad too, and yours just sounds like a lovely, wonderful man. And I wanted to say that. now the money. Yeah, when we talk about the 900 etc. million, that's excluding IAPT. This is for CMHT development. And Viral, who got a plug earlier, and my national team spend a lot of their time working with regions through to systems to try and shepherd that money through to its intended cause. So we've got 2.3 billion in total. So the other 1.45 billion is for the rest of our long-term plan commitments. So yes, this really is for community mental health development, which is why it's such a fantastic opportunity. We can't take our eye off the ball for a moment. In terms of Treasury, look, on capital, there is absolutely no doubt that we are in a really competitive arena right now, and one has to feel a bit sorry for our Treasury in our country right now as they make decisions about what's most important. But myself and my colleagues, and I have to say Nadine Dorris, our minister, has been really good on this front, are just going to keep batting really, really hard for mental health capital. And Simon Stevens used that phrase himself, the Chief Executive of the NHS. So it is hard. We can't take our eye off that ball for a moment. We need more new hospitals, not just the ending of dormitory provision, and we need our share of those for mental health as the capital flows for them. But actually, and my colleagues on the national team have been working with colleagues across the country, actually we also need investment in the community infrastructure as well. So you're absolutely right, whoever said that 400 million is not enough to do it all. It absolutely isn't. Our ask of Treasury is considerably more. And yeah, we'll go in and advocate very, very hard for that investment.
Thank you, Claire. Mark, I'll direct the next one to you, because obviously this is something that Rethink and other organisations in working in places, somebody once said to me, a place is just somewhere, but working in places have experience of, which is really that connection between the local authority and the health trust. And person here saying that in this case, the local trust refuses to work with local social care and voluntary organisations, and that's a huge issue for people living with, for example, PTSD and who are at risk of suicide. So Mark, I mean, why, I suppose, is it important, dare I say, that those two different agencies work together hand in hand?
Thanks, Brian. And obviously, it features quite heavily within our guide the importance of that kind of joint working across the STP between local authority, NHS, and the wider system. I think there are two reasons that absolutely stand out. First of all, both parts of the system are no doubt going to be at some point seeing the same people and working with the same individuals and having those connections with people living with mental illness, and the fact that actually there are two parts of the system that aren't talking to each other, then makes that more difficult for those individuals to navigate those services. And I think the other one is that actually it means that the investment in the system can go further and be used more efficiently. So if local authority commissioning and health commissioning are talking to each other about their plans for developing servicing those areas, it just feels obvious that the best way to do that is by thinking collectively about, well, how do we deliver this in the best for the best experiences of our combined population. Ultimately, you think that those organisations have a common goal around delivering better services for people. So you would think that money and income would go further if it was working across all of the system and not just parts of it. And ultimately, that drives better outcomes for people who will use services.
Great, thank you, Mark. The next question is really around how to best involve people who are either carers or with lived experience, and really that's kind of sense of not feeling confident about co-producing. I think there's also kind of tension about the ambition to move quickly, which is incredibly welcome with the desire to get this right. So Kate, I mean, from your perspective, you know, how would you have liked to be involved in shaping that offer for your dad that best helped him live that kind of full life that you described so well?
I think what would have been key is more, well, I guess better access to peer-to-peer support. So we didn't know anyone else with Dad's diagnosis, no other sufferers or their families. And I think it's a bit of a you know, something we battle with is that we don't really feel like we understood the half of what Dad was going through, actually, because we didn't have anybody else to talk to. And to be fair, like because Dad seemed to cope so well, we didn't necessarily reach out and try and access these things. But I also think it's a case of making it really obvious to people where their point of access is and what all the different options are, and yeah, creating opportunities for people to link up and share their experiences, I think could have been so beneficial and would have been so beneficial for us.
Great. Thank you, Kate. And then I think the last question that we'll have the space for is around that issue of stigma. And again, I'll kind of direct this towards you, Claire, if I can. It's still so prevalent even within mental health services themselves. And particularly on personality disorders, as you indicated. So will there be money for awareness training on personality disorders?
So I think we're hoping, I mean, well, look, firstly, I think stigma is still such a live issue, and I think it was 1982 or 1983 when an MP stood up in the House for the first time on his maiden speech, Chris Smith, and basically said, yes, I'm a new MP and I'm gay, get over it. You know, people are different. And, you know, it was something like 2012 before MP stood up in the House and said, yeah, I suffer from mental health problems or a mental illness. And 4 did it at that time, 30 years behind. And that was a massive step. I remember crying on the way home from work at about listening to the 9 o'clock news that MPs had stood up and done that. It was very brave of them. And when I emailed them at midnight that night, both of them had got back to me by 6 in the morning. And I doubt they'd slept at all at the enormity of the step they'd taken, but I had huge respect for them. And I agree, we've come a long way. There's been a brilliant campaign with the Royals, with celebrities, with others coming out. We had a celebrity recently coming out talking about his bulimia, his eating disorder, didn't we? And so I think we've come a long way. I completely think that within the system, people with the label personality disorder are discriminated against, which is why our development of community mental health teams is placing so much emphasis on trauma-informed care. Now, in order to deliver trauma-informed care, actually your service spec, who you're recruiting, how you're training them, the sharing of best practice, a whole programme of developments to, and certainly the introduction of more and more peer support workers working in services whose job isn't just to help deliver care, but help shape it and help raise awareness within teams. I think there are several things that we are doing to try and make sure that we tackle the stigma that can exist both within and without. So we've come a long way, but we've got at least as far to go again. And with organisations like Rethink, the people who are on this call today, on this meeting today, and many, many more, I feel very optimistic we will get there, but not soon. We've just got to be indomitable and keep at it because we're making progress.
Claire, thank you so much. And I think that feels like almost a perfect place to stop, because it's about that tightrope that we're trying to walk, isn't it, between the ambition that comes from decades of trying to get this right, but the reality that we're in very difficult circumstances at the moment. But we just have to get started. You know, that cliche about every journey starts with the first path. Well, it's not like none of this has been in place, but I suppose the question is, what's a reasonable place to get to by when? And I think, hearing what everybody has said, my sense is if our ambition is to have that rounded care model, that biopsychosocial model, or as Kate put it, all of those things that make such a difference to your quality of life for everyone, no matter where they live, perhaps that by April it's reasonable if people have identified a leadership team to take it forward, have given some thought to what a co-produced framework begins to look like. Perhaps identified those areas within their STP which can move quickest and be that have that demonstrator value. Identified that voluntary sector alliance that can help build that capacity to make sure that the assets are in that local place to deliver, and have given some serious consideration what the workforce looks like to meet that. Then you'll be well on the way, because it's a journey. Nobody's expecting that destination to be reached by April the 1st, but it's a journey to, and if you don't start down that road in the right manner, you're much less likely to get to the destination. So final two thoughts, really thank you so much to everybody for coming. As we said, it's the first in a number of webinars, and we will be doing one with our colleagues in Somerset, and I think the link to that is on the side if you want to register for that. We will talk a bit more about our experience there. So all really that remains for me to do, I think, is to thank our three guests, Claire, Kate and Mark, and all of you for joining this. I think it's been a fantastic discussion. We will follow up with some of those questions which we haven't had a chance to answer. I'm sure that you will have many more that we can support you with, hopefully in the coming months and years. So do get in touch if you'd like us to work with you. And in the meantime, very best of luck for your journey, your transformation, and for the change that you're trying to make in your community. Thank you.